Assalamualaikum Dato'. I'm Isa, second year student from Lincoln University College. Today I would like to do the physical examination on you. If you don't mind, I need you to take off your shirt and expose your body.
Make a general inspection of the patient's demeanour, body mass, any chest deformity or scars, and whether they're confused or distressed. Look for equipment such as inhalers or oxygen support. Measure the respiratory rate and observe the respiratory pattern. Note any unusual effort or noise in breathing such as stridor. Assess the radial pulse and check the blood pressure. Look at the hands for tobacco staining, peripheral cyanosis and finger clubbing. This is most commonly associated with lung malignancy, fibrosis or chronic infection. Hypertrophic pulmonary osteoarthropathy includes finger clubbing, check for tremor in the hands. Watch for a few seconds. A coarse flapping tremor is seen with severe ventilatory failure. To detect lateral shift of the trachea, gently place the tip of your right index finger into the suprasternal notch. This can be uncomfortable, so be gentle and explain what you're doing. The distance between the suprasternal notch and cricoid cartilage is normally 3 to 4 finger breadths. Feel for a tracheal tug, which may be found in severe hyperinflation. Use your hands to detect chest expansion, which should be symmetrical. Watch how your thumbs move. Reduced expansion indicates abnormality on the same side. Percussion allows you to hear the pitch and loudness of the percussed note and feel for post-percussive vibrations. Percuss sequentially over corresponding areas on both sides of the chest. Percussing over normal lung produces a resonant note. Over solid structures, for example the liver or heart, a dull note is produced. Place the palm of your left hand on the chest with your fingers slightly separated. Press the middle finger of your left hand firmly against the chest, aligned with the rib, over the area to be percussed. Strike the center of the middle phalanx of your left middle finger with the tip of your right middle finger. Use a loose swinging movement of the wrist. Remove the percussing finger quickly so the note generated is not damped. Work down the chest from side to side, comparing left with right. Most sounds are best heard with the bell. Auscultate left and right alternately, comparing equivalent positions, to ensure that localized abnormalities are not missed. Don't ask the patient to take exaggerated breaths for a prolonged period, as this may cause dizziness or even tetany. Listen anteriorly from above the clavicle down to the 6th rib, and laterally from the axilla to the 8th rib. Assess the quality and amplitude of the breath sounds. Identify any gap between inspiration and expiration, and listen for added sounds. Bronchial breathing is a high-pitched breath sound with a hollow or blowing quality similar to that heard over the trachea during tidal breathing. Bronchial breath sounds are found when normal lung tissue is replaced by uniformly conducting tissue and the underlying major bronchus is patent. This happens with pulmonary consolidation from pneumonia at the top of a pleural effusion and over areas of dense fibrosis. Next, examine the neck and chest from behind. Examine for cervical lymphadenopathy. Systematically work your way through the lymph node groups. Start anteriorly with the submental and submandibular, and then the upper, middle, and lower cervical nodes. Also palpate the posterior triangle along the border of the trapezius muscle and the supraclavicular fossa. The post-auricular nodes are felt behind the ear and the scalene nodes are above the first rib. Inspect the chest from the back, looking for deformities of the spine or chest wall or thoracotomy scars. Repeat the assessment of chest wall expansion posteriorly. Place your fingers along the ribs and watch your thumbs to track the motion. Percuss the chest posteriorly. For the superior part of the posterior chest wall, ask the patient to fold their arms, abducting the scapulae. Do not percuss near the midline, as a dull note is produced from the solid thoracic spine and paravertebral muscles. Map out any abnormal areas by percussing from resonant to dull. A pneumothorax will produce a hyperresonant note. Percussion over a solid organ or consolidated lung produces a dull note. Fluid, such as a pleural effusion, produces a very dull note described as stony dull. Basal dullness due to elevation of the diaphragm is easily confused with pleural fluid. Repeat auscultation on the back. Again, compare left with right and listen at a good number of positions to ensure you don't miss a localized abnormality.
Okay. Now we are done for today. Thank you, Dato'.
Okay, can you check my shirt?
Oh,